So next we'll start with GA pathology. So under GA pathology, we'll be dealing with Barrett's esophagus, the various esophageal tumors. Then we'll move on to stomach, wherein we'll see about gastritis, peptic ulcer diseases, and H. pylori. Then we'll see about gastric tumors like gastric carcinoma and maltoma, and also gastrointestinal stromal tumor. Then in intestine, we'll see about the ulcerative lesions, the various malabsorption syndromes, inflammatory bowel disease, the various polyps, and colon cancer. So let's start with Barrett's esophagus first. So Barrett's esophagus is actually a metaplastic change happening in response to irritation caused by the gastric acid. So this Barrett's esophagus is going to happen at the lower esophageal end. Okay, so lower esophagus, it usually happens in patients who are having gastric esophageal reflux disease. So whenever the patient is obese or having some smoking history or usage of other alcohol, so they'll have a trouble in their lower esophageal sphincter. So once this sphincter is lax, so what will happen? The gastric acid produced in the stomach is going to regurgitate into the esophagus. So it is going to come up into the lower esophagus as well. So normal lining of the esophagus is going to be stratified squamous lining. But when this acid is being regurgitated, slowly it is going to irritate the squamous epithelium and it will cause inflammation. So what will happen? The esophageal lining will try to adapt to this irritant stimulus. Okay, so the esophageal stratified squamous epithelium will become into a intestinal lining. So it will undergo metaplasia and become an intestinal lining. So why? Because intestinal linings usually have goblet cells. So when goblet cells are there, it is going to produce mucus. So mucin is going to protect this acid. So in order to counteract this acid irritant in the lower esophagus, the esophageal lining is going to undergo metaplasia into a intestinal lining. So this is what we call it as a Barrett's esophagus. So what is Barrett's esophagus? It is going to be just a cellular adaptation, which is a metaplastic change. So being a cellular adaptation, it is going to be reversible. Okay, reversible change which has occurred in response to the irritant stimulus, which is the gastric esophageal reflux. Okay, and what happens because of that? It is going to cause intestinal metaplasia. So what is the hallmark of intestinal metaplasia? It is going to be the presence of goblet cells. So goblet cells which produce the mucin is going to be the hallmark of intestinal metaplasia or Barrett's esophagus. So how does it look like on endoscopic image? So if you put an endoscope here, all of this part, this white area, right? So this is all the normal squamous lining. So squamous lining will produce keratin. So this is going to be the normal squamous lining. While in this red color, tongue-like projections are seen, right? So doesn't it look like a tongue? So these tongue-like projection extending from the gastroesophageal junction towards the esophagus are going to be the Barrett's esophagus. So to call it as a Barrett's esophagus, you will have to see these salmon colored tongues which appear red and velvety proximal to the gastroesophageal junction for at least 1 centimeter or more. So this is how endoscopically Barrett's esophagus is diagnosed. On microscopy, biopsy being the gold standard. So on microscopy, how do you identify Barrett's esophagus? Because this is the squamous lining. So this entire part will be the squamous lining, which is the normal esophageal lining. Now here, if you see, it has all undergone intestinal metaplasia. So in continuation, you are seeing intestinal metaplasia. So intestinal metaplasia, so all the cells which appear empty or having some bluish material, no? So these are the goblet cells. So goblet cells being a classical feature of large intestine. So goblet cells are seen. So this is what is called as intestinal metaplasia. So how do you confirm that it is Barrett's esophagus? You can apply a stain called as Alcian blue. So Alcian blue is a stain which will stain the acidic mucin. So it will stain the acidic mucin produced by the goblet cells, and here it uses a pH of 2.5, so very high acidic pH. So 2.5 acidic pH, it will stain the acidic mucin as light blue. So here again you see the squamous lining, and these are all the intestinal fossa in which you can see these light blue colored areas which are staining the goblet cells mucin actually. So Alcian blue stains acidic mucin. So Alcian blue can be used to confirm the goblet cells in Barrett's esophagus. So why is it important to know about Barrett's esophagus? Main thing is because it is going to have an increased risk of adenocarcinoma. It is a pre-neoplastic condition. So slowly this even though Barrett's esophagus is a metaplastic condition, when this is persistent and it can acquire further mutations like p53 or rb mutations, and then it can convert into a adenocarcinoma in the lower esophageal end. So that is why Barrett's esophagus is quite important.